Okay, we'll get started. Kia ora, everyone. I'm going to hand it over to my colleague Sue Reed to do our welcoming karakia.
Kia ora, kia hora te manino, kia whakapapa punamu te moana, kei horahi ma tātou I te rangi nei, araha atu, araha mai, tātou I a tātou katoa, hui e tai ki e.
Thank you so much, Sue. Before I introduce Anna, I just want to do a few housekeeping and announcements. So if you could just please keep your microphones muted during the presentation, that would be appreciated. Also, I just want to encourage you to keep an eye out for our next invitations that are coming up. I'm not sure if we'll have one in December, but certainly next year we've got some really exciting speakers lined up for you as part of this series. Also, if you have any interest in sharing your research or your work in this space, please reach out to me. I'd be happy to chat with you and see if it's a fit. And if you have ideas of anyone that you think I should be contacting to talk about sexual and reproductive health and rights over the life course, it's a pretty wide remit intentionally. And finally, I just wanted to mention we have just started an advocacy survey. We're asking people to share their experiences seeking menopause services and advice in New Zealand, Aotearoa. So I've just sent through that link in the chat. If you have any interest or would be willing to share it around, we'd really appreciate it. So without further ado, I am absolutely honored to have Anna Adcock with us today. So Dr. Anna Adcock Ngati Mutunga is a senior research fellow at Te Tate Haora o Hine National Center for Women's Health Research, Aotearoa, at Victoria University of Wellington. Anna does kapapa Maori, so by Maori, for Maori, sexual, reproductive, perinatal, and family health research that centers on the lived experiences and perspectives of whānau Maori. She often uses community-led approaches. She's passionate about health equity, data sovereignty, research ethics, and whānau. After she obtained her master's degree in sociology at Victoria University of Wellington, she completed her doctoral thesis, a qualitative longitudinal research study exploring whānau Maori experiences of preterm birth. Other maternal infant health research Anna is involved in is looking at postnatal support for whānau and infant neurodevelopment support for whānau impacted by methamphetamine. She is also currently working on a body of research, He Tapu Te Whare Tangata, the Sacred House of Humanity, to inform the National Cervical Screening Program, which is what we'll be hearing about today. So I'll stop there and just hand it over to Anna. Thank you all for joining us.
Oh, kia ora. Thank you for that introduction, and kia ora koutou katoa. As Ragnar has said, I'm here to talk today about He Tapu Te Whare Tangata, which is a body of research with the goal to contribute towards the equitable elimination of cervical cancer here in Aotearoa. And He Tapu Te Whare Tangata, the name of this work, as Ragnar said, means the Sacred House of Humanity, tapu being sacred or restricted, and whare being house. And you can see on the screen, this is the whare at Te Herenga Waka, the marae up here at Victoria University, and tangata being people or humanity. And whare tangata is the te reo Māori term for the womb, the neck of which is the cervix. So whare tangata is also a term used for women who have wombs. So this name really reflects the veneration of Māori women as whare tangata, and the womb as the whare tangata. And when we talk about te whare tangata as in the womb, we are talking about women and people with cervixes. And this body of research has a Kaupapa Māori foundation, which is by Māori, for Māori, with Māori, and it's really strengths-based. And so rather than trying to explain inequities through deficit discourses around individuals, instead looking at structural issues and trying to find solutions. And this kaupapa Māori research really emphasizes the importance of tino rangatiratanga, of our sovereignty as Māori over research that is about Māori, research that is for Māori. So I'm not sure who's in the room and what your backgrounds are, but I'll just really quickly go over HPV's linked to cervical cancer. So HPV, or human papillomavirus, is a very common virus. Around 4 out of 5 people will have it at some point in their lives. It's sexually transmitted. And for most people, the body will work out that infection and nothing will happen. No cancer will develop. But for some people who get a persistent infection with one of the cancer-causing types of this virus, and it's usually classed in 2 groups, either HPV 16 or 18, which are the most common cancer-causing types, or HPV other, which is a group of other cancer-causing types. HPV also causes other cancers, not of the cervix, and also things like genital warts, but these are different types. So it's usually a long, persistent infection, which starts to cause the abnormal changes in the cervix, which leads to cervical cancer. And when we test for HPV, it's usually using a PCR test, which is the same kind of test that's used to test for things like COVID, chlamydia, gonorrhea. It looks for really tiny amounts of the HPV DNA from a sample, which is usually taken from the vagina, not the cervix. And it can find in that sample what kind of HPV it is and whether it's an oncogenic or a cancer-causing type or not. And at the moment in Aotearoa, our cervical cancer incidence rate is about 5.9 per 100,000. But for Māori, that is 9.1. And for Pacific peoples, that's 8.4. So there are inequities in the incidence of cervical cancer. And with that, there are inequities in mortality as well. Wahine Māori are around twice as likely to die from this preventable disease. And so we, as a research group, have been really interested in what the World Health Organization has been doing over the past decade, really, around the elimination of cervical cancer. So they had a call to action in 2018 and then released their strategy in 2020, which has focused on low resource settings where there are, the rates of cervical cancer are greater than they are here in Aotearoa. However, we can learn from the strategy what we need to do in Aotearoa, and also think about what we need to do for equitable elimination. So elimination is deemed as less than 4 people out of 100,000 of the for the incidence rate. So 4 or less. And so as I said previously, currently it's 5.9 in Aotearoa, but 9.1 for Māori and 8.4 for Pacific. So we have some work to go to achieve elimination for the general population, and we have much further to go to achieve elimination for Māori, for Pacific, for groups who have historically been underserved by our screening system. And so as part of this WHO strategy, there are 3 pillars to achieve elimination of cervical cancer as a public health problem. Pillar 1 is around vaccination, pillar 2, screening, and pillar 3, treatment. So really briefly, the WHO classifies their vaccination pillar on 90% of girls being fully vaccinated by 15 years of age. Currently in Aotearoa, we've had a school program since 2008, which at first just did vaccinate girls, but boys were added in 2017. And it is free for all 9 to 27-year-olds, so through school, but also through, pharmacies, primary care. And so for pillar 2, for screening, the goal or the target is 70% of women are screened by a high performance test, which is an HPV test or better, because technology moves on, by the age of 35 and again by the age of 45. Now with the HPV test, which I'll talk about more in detail soon, with a negative HPV test result or a not detected, the interval between screening is 5 years. And in the future, that might actually get longer as well. So we historically in Aotearoa, as I'm pretty sure everyone on this call would know, have had a national cervical screening program since 1990. It was based on liquid-based cytology, started as a pap smear and then continued to be called a smear. And that only just changed in 2023 in September. So 2 years ago and a little bit, we moved from the liquid-based cytology as the primary screen to an HPV test being the primary screen. Still offered through primary care and recall as it was before. And I'll add that there is a cost to screen, and there is some funding for priority groups, but that's not always available everywhere. And this is the only screening program that has a cost. Other screening programs are free. So now the third pillar is around treatment. 90% of women will be who have low grade or pre-cancerous disease treated, and 90% of those who have cancers treated. And in our current system, it's either publicly funded follow-up, or people can opt for private follow-up, which may be faster. And our body of research here, Tapu Te Whare Tangata, is really focused on the screening part of this picture, but it's really important to keep these other parts in mind and how they overlap as well. So how are we doing in Aotearoa for vaccination? Our regions vary quite wide, between 43% full coverage, so that's 2 doses, to 75% coverage. The average is about 64% across Aotearoa. It's a school-based program, as I've said before, and the rates are actually falling. If we look at just this last quarter and the percentage of the eligible population who have received 1 dose, which provides good coverage but not full coverage, we can see that we're, in the range of, 40 to 70% have received 1 dose. Sorry. And so this is really it's not good enough in terms of moving towards elimination. We need to get those percentages closer to 90%. We have a strength is that the vaccination is offered and free for all, boys and girls, not just girls. So that will offer some further protection. But we need to get those vaccination numbers up. For example, in Scotland, they have close to 90% vaccinated, and they have had no cases of cervical cancer in women born between 1988 and 1996. So those who were fully vaccinated against HPV between the age of 12 and 13. This is what we want to be seeing everywhere. Yeah. So the second pillar, which is really where we have been doing a lot of work, and it is a good news story in that our primary method of screening has changed to the HPV test, which is better as a cervical screening tool. It is more protective, and so there's been a lot of studies internationally, big trials, big RCTs that have shown that this is a more effective test at preventing cervical cancer than cytology. And also, really excitingly, that doing a self-test, a vaginal swab, so taking out the need for a speculum examination on someone who's asymptomatic, that this is just as effective as a clinician taken sample for detecting HPV, for preventing cervical cancer. So obviously if someone is symptomatic, then they should have a pelvic examination, and that is a whole nother thing. But for a screening program, the self-test, being able to do the test yourself is just as good as a clinician taking the sample. And when we started doing this work 10 years ago, that was a real concern, that it wasn't, a clinician should be taking the sample. But with this test, that's just not the case. Like I said, for asymptomatic people who don't have any other reason why they should have a pelvic examination. So between September 23 and 2025, almost 800,000 HPV primary screens were done, and most of those were self-tests. People can still choose to have the clinician take the sample if they want to, but most of those have been self-tests, and that has increased the screening coverage quite dramatically. And I'll move to the next slide, that there was actually a dip around COVID. So our screening rates were already not great, especially for Māori, Pacific, Asian women. And COVID, they went down, and then this new test was brought in, and you can see that it's trending upwards. And apparently, I've heard it is still trending upwards. So the screening coverage is improving still. And so what does this mean for equity? Māori rates are almost at 70%, which, if you remember, is that World Health Organization target for screening. Pacific have exceeded 70%, and there's an overall relative increase of 11%. And I'm not a numbers person, but I have been told by numbers people that is a very significant amount. And when you're looking at a whole population level, this is going to save a lot of lives, because it will be catching pre-cancers early, preventing cancer from progressing. And I think we really need to appreciate the success of this, and that this is a really monumental point in time for wahine, for people who have cervixes, that this new screening test is both more comfortable and easier and less invasive, and also better. So it's, better, emotionally, psychologically, physically, and a better test. And so we are definitely not the only group of people who have been working towards this and informing these changes, but we have, had some really key learnings along the way that we have, through good relationships with Manatu Hauora, the National Screening Unit, Te Whatu Ora, and have been able to feed back into it the program, this new program itself, along with others who are working in this area. And and then, on the ground, health services who are doing their own work, and community groups, campaigns like Smear Your Mare. This has been a really collective effort. And I think we can learn from this for other areas where we want to see equity improved, where we want to change how things are done. And so, as I said before this, we've been doing this body of work, He Tapu Te Whare Tangata, for about 10 years. And it's all started with a piece of research that was mixed methods. So it was both quantitative and qualitative. We talked to over 100 never screened or under-screened Māori women about whether they would potentially do an HPV self-test if they were offered it. What should that look like? What do wahine Māori want? And so this was funded by Te Manatu Hauora and the National Screening Unit. And we surveyed almost 400, again, never screened, under-screened wahine Māori from across Aotearoa. And resoundingly, we heard that, yes, this sounds like a great idea. And the survey, almost 3/4 of survey respondents said they would be likely or very likely to do this test if they were offered it. And so this piece of research was really the start of everything that's come since then for our research centre, and working closely with the National Screening Unit on this has really, so the voices of these wahine has really informed the new program. And yeah, and it was from that work, from talking to wahine Māori, that we were able to design an RCT that in Te Tai Tokerau Northland, which compared the uptake of an HPV self-test, although people could choose to have a clinician take the sample if they wanted to, compared to the uptake of standard care for never screened and under-screened Māori. So the focus was really, how do we get never screened and under-screened Māori access to screening that's appropriate. And then we also received some funding from the Cancer Society to talk to some of the people who had done the test as part of that study. The trial itself was open to, it was a cluster randomized controlled trial. So we had clinics that were part of the control, and we had clinics that were part of the intervention, and anyone in the intervention could do the test, so not just Māori, but for our results, we were looking at never screened and under screened Māori. And, we heard that it was a great test, and that people wanted to be able to continue to screen in this way. And on the numbers side, almost 3 times as many never screened and under screened wahine Māori screened in the intervention clinics than they did in the control clinics. So it's a really large difference, and really that was also informing the National Screening Unit at the time about how, not just how the HPV self-test could be offered through primary care, but also around the pathway to follow-up and treatment following an HPV detected test. Because we found that for never screened and under screened wahine Māori, going from an HPV detected result on a self-test to a referral to colposcopy was difficult for the wahine, and also difficult for the colposcopists, because they were finding they had to go through a lot of information and support to ensure that the colposcopy visit was seamless. And so that ended up feeding back into the program extra time with colposcopists. So the colposcopy visit, more time being funded for never screened and under screened women. And of course we were learning things as well about how we explained things as part of the research, since this was not available publicly at the time. And the technology was also moving on really fast as well. And so we started looking at point of care testing results, point of care test results for the self-test. And so if you haven't heard of it before, you might have a pointer. You can see in the little photos, they're a bit small, but a point of care machine, and I believe we've used the Gene Expert, is just a really small little machine, and you can have it in clinic, and it will take the HPV self-test swabs and run it through the system in about half an hour or an hour, and you'll have the result right there in clinic, whether HPV is detected or not. And so we have been working with Ngāti Porou Oranga in Tairāwhiti, and also Ngāti Pāhauera iwi in Wairoa, and the health clinic there in Wairoa, to have these machines in the clinics to see does having the having the machine to process the test and get the results, does that improve community control over the whole pathway, especially when someone has an HPV detected result? Does that mean, like I alluded to before with our big RCT, well, maybe internationally it was a small RCT, but big for here, that getting that pathway to colposcopy following an HPV self-test result was really important. So in these rural clinics, does having the machine and being able to have a result within an hour and deliver that result to the community, and then refer on to the appropriate services, which are often colposcopy clinics not in these communities. So sometimes they were, depending where people lived. For example, up the coast in Tairāwhiti. So we wanted to know if this helped that pathway. And we heard really positive things. So we've got a quote here from a wahine saying, "Ka tū ngā wahine I tirohia I whakamua." This was someone who did the HPV self-test, and said, we as women, we're standing up and we're looking forward. And this was her way of really advocating for the HPV self-test. And we've heard really positive things from the point of care test operators. So these are all, clinicians, mostly nurses, who are trained within these rural clinics to run these machines. So to process the results and to also do quality assurance checks. It's, time consuming on top of people's already busy lives. But we've found that that wasn't the time consuming aspect wasn't enough to make the clinics say they didn't want to do this anymore. In fact, the clinics have all become champions for point of care testing, and doing some more work in those areas at the moment. But and in terms of that follow-up pathway, so from receiving a positive result and going to either having cytology, which is at the time it was the NSU proposed guidelines for HPV others to be referred or recalled for cytology, and for HPV 16 or 18 detected results for those people to be referred to colposcopy. Those were the guidelines at the time. But for our studies, we had heard previously that wahine didn't want to have the cytology. If they thought that there was something potentially wrong, they wanted to go straight to colposcopy. So in this study, actually, all wahine with a positive result were referred to colposcopy. And so this again was a trial where clinics weren't randomized, but clinics were the crossover trial part it was between Wairoa clinics and Tairāwhiti clinics. And so, first of all, one of those groups got the point of care testing machines to do the results in clinic, while the other group got HPV self-tests and then the usual laboratory results as they would for cytology. And then they crossed over after about a year so that the other group of clinics got the point of care test machines and the other clinic got the laboratory referral pathway. So those who had a positive HPV result were 4 times more likely to be seen at colposcopy within 20 days of the test when they were on that point of care test pathway. And they were 3 times more likely to be seen at colposcopy within 40 working days of the test using the that point of care pathway. So 3 times as likely, 4 times as more likely to be seen within 20 days, or 3 times more likely to be seen within 40 days. And when I get to that last pillar soon, maybe that'll make it a bit more sense. And the last project that I just wanted to briefly introduce was, so all this time we've been learning from wahine Māori and being guided by wahine Māori about what works and what doesn't in terms of HPV self-testing. And so then we got this big study funded by the HRC and by Te Whatuora to do a non-inferiority trial of a universal offer. So not just focusing on under-screened or never screened Māori, but what happens if we say everyone that's due for a cervical screen gets offered an HPV self-test? Is that non-inferior to usual care? Everyone who's due for a screen is offered the liquid-based cytology, the smear. And this was up in Te Tai Tokoro again. And we had a lot of different clinics that were randomized depending on size. And so the idea was to offer everyone who is due the screen with the HPV self-test, and just to say it's not inferior to standard care at the time, which was the liquid-based cytology. What we found was it was non-inferior, but it's not just non-inferior, it was better. So it's superior when it's offered universally, as it would be in as the normal program goes. If it's offered to everyone, the screening rates were 1.68 times higher than they were in the groups that were the comparison. And I'm not a quantitative person, but analysis was adjusted for age and ethnicity and NZ deprivation and screening status. So this is not quite published yet. It's still undergoing review, which is why I haven't put much up on the screen, but you can look out for that paper. Hopefully will be published in the new year. And so this is all just going into that kete, that bag of evidence for the National Screening Unit, that HPV self-testing is the right way to go, because at this point it had actually been announced that the program would change years before this, but then there was a change of government, change of this and that and that. So the new program had been delayed by a few years. We actually stopped this trial when the new program finally came into effect in September of 2023. And so the last pillar around timely treatment, and what we've heard throughout the 10 years of research that we've been doing, and more recently around the point of care testing and that community control of the pathway, is that we really need to wrap support and care around those who have an HPV detected result to ensure that they are in the best position to receive the follow-up, the treatment that's recommended, and that there is capacity to treat people in a timely fashion. And so in this most recent quarter, if we're looking at timely access to assessment and treatment, this is this is the overall population. So how many people are being treated within 30 days and how many people are being treated within 40 days. And you can see this is Te whatu order parameters. The World Health Organization, as far as I know, doesn't actually have a specific timely treatment, discrete, nice little this amount of time. And so, like as with the other pillars, there will, it will depend on the country, on the policy, on what is being offered and how that aligns with the pillars. So for us, this is our best but our best idea of timely treatment. And if you remember the pillar, the target was 90% treated in a timely way. So if we're looking at this as being seen at colposcopy within 30 days of a referral or within 40 days of a referral, anywhere on that table, you'll see we're not close to 90%. So just, keep that on board. And so looking at the whole World Health Organization elimination targets, how are we doing? Well, for HPV vaccination, you saw we're nowhere near 90%. And yes, we are immunizing boys and girls, which provides extra protection, but we're still nowhere near 90%. For screening, the WHO target is 70% having received an HPV test or better by 35 and by 45. We have over 70% coverage overall. We don't quite have 70% coverage for Māori. So although I think you could say we've had a lot of wins here, we actually still have a way to go to ensure that if we do reach elimination, which we probably will eventually, that it's equitable. It's not just an overall elimination. We don't still have these glaring inequities between Māori and non-Māori in terms of incidence and mortality. And treatment, as I just talked about on the last couple of slides, we're nowhere near 90% treated if you're taking the the 30-day, 40-day thing as timeliness. So we have a lot of work to do in those areas. Now, some other nations have put a time on when they are going to eliminate cervical cancer. Australia says by 2035, based on their modelling. They probably will. I don't think it will be equitable for Aboriginal and Torres Strait Island peoples. The UK says that they will eliminate cervical cancer by 2040. But for us in Aotearoa, we don't have that modelling yet. We don't have any statement about when we will eliminate cervical cancer. And for us as a rōpua, we're a part of a big team. I'm definitely not like the main event, there's heaps of us, and we work a lot with government, with community, with iwi, with international collaborators in Australia particularly. We really want to see cervical screening free, and we will keep advocating for that. It should be free for all, in particular for priority groups. But really, why is it that cervical screening comes at a cost when other screening programs don't? It doesn't seem like women's health is being prioritized. We need to ensure that people who have an HPV test have support to colposcopy, and that is around, that can be through transport support, through, kaiawhina, or, people, aunties being their emotional support, and also through ensuring that our health services are funded and are running in a way that they have capacity to see people quickly. We would love to see leadership in this space, and for Aotearoa to have our own targets, to have a task force that we're all involved with, that we're all working together for. We want to see an elimination strategy for Aotearoa, and one that is equitable, that does just not say that that elimination is achieved when elimination is only achieved for Pākehā. It should be elimination, even if we're saying it as in, in the crude, maybe not crude's the right word, but in the numerical terms, but it should be for everyone. And my boss, Professor Bev Lawton, is really suggesting that if we have our own targets of 90% vaccinated, 90% treated, actually our screening target, perhaps we should go for 80%, because that's what our screening target has actually been all along, 80%. Never not being met for Māori or other groups, but should we keep our screening target 80%? And we must learn from other people's successes. Like I have an image here from the Smear Your Mare campaign. Community groups who are doing the work at flaxroot or grassroots level, who know their communities. Tūruki Health in Auckland is another group who I was going to mention, but probably don't have time to go into detail, but have been really putting time and effort into supporting their communities, on the ground, knowing their communities, doing, changing, being evidence-based to increase screening rates, especially for Māori and Pacific. and we want to see the screening program, a screening program that that supports that, encourages that because there's no one size fits all approach that actually works. And I know this is a screening program, which, public health is kind of, very much into that. This is the thing for everyone. But actually, how can it be more whānau-centered, more people-centered, to ensure that no one gets left behind? And I haven't talked about other HPV cancers, and it's probably better that I don't because I am not a clinician. I forgot to say, though you might have guessed from Ragnar's introduction, I'm a social scientist. I work with a lot of clinicians, but I am not one. But the vaccination the vaccination protects against other cancers, head and neck, oropharyngeal, anal cancers. It's really important that we, I think, keep all these pillars in the conversation, even if we're focusing on screening. That there needs to be, we need to think about vaccination and treatment as well, and the same for all of those. And I'll just like to end by acknowledging that He Tapu Te Whare Tangata, this body of work that I've been talking about, has really, is there because of the many hundreds of wahine Māori and also non-Māori who have participated in our different studies over the years and contributed their data, which is a taonga, to this, because they want to see change. And also our other collaborators who we work with and funders. And yeah, I think I'll just finish by saying tēnā koutou, tēnā koutou, tēnā koutou katoa, and happy to take any questions.
Great. Thank you so much, Anna. That was a really lovely and comprehensive overview of those three pillars. And I feel like you gave us such a firm foundation to stand on in improving our understanding of this topic. So thank you for that. I know there were some questions in the comments, but I see that some of those inquirers are still here. So I want to offer people to unmute, raise their hand to answer a question. Esther, I know you in particular had a couple things that you wanted to ask.
Oh, kia ora.
Kia ora.
So just kia ora. Thank you. This was super interesting. And just those two questions. If there's any mahi specifically around transgender people with the cervix and non-binary people with the cervix and refugee communities and migrant communities who may not understand the about HPV or there may be some stigma or hesitation. Yeah, thank you.
Thank you for that question. It's really important. We don't have the data to really speak to that. I know there are other groups internationally who have done some work with transgender communities. We didn't specifically. We have anecdotally heard that from clinicians who have been involved that this has been acceptable for non-binary peoples, but from our interviews with people, we haven't captured any of that, unfortunately. I think it's a really important area of work. And in terms of maybe migrant communities and other peoples, that was another area that we haven't looked into specifically, but there are some other groups, Karen Bartholomew's group up in Auckland, Waitemata, and also Peter Sykes. He's done some work down in Te Waipounamu. They may have covered more of those other groups. So sorry, I don't have anything necessarily to add. But yeah, from international studies that have been amongst lots of different, I'll say, underserved communities, for want of a better word, that this is the HPV self-test is a lot better. And I think for me, as someone, you know, I think the way we talk about it is also really important. And I tend to fall back into talking about women a lot as well, but really try to bring it back to women and people with cervixes. And I think that's another area where we have a long way to go. But I think it's really good that it's becoming more, that maybe language is becoming more inclusive, but we can do better.
Thank you, Esther. There was another question in the chat from Micah, but it appears that maybe Micah has left. So I just want to open it up. We just have about 3 minutes left. If anybody else has a question, if you want to turn on your video, raise your hand, or use the react button to raise your hand. Okay, Esther's just sent through a link, which looks like a really interesting piece of research, it sounds like. Okay. Imogen, you've joined on video. Did you have something you wanted to ask? Oh, we cannot hear you, I'm afraid.
Can you hear me now?
Yes.
Awesome. Hey, sorry, Micah had to hop off the call, but I am in the same team as Micah and just wanted to hear if there was any response to his question and I can pass it on to him.
So the question was, just to clarify.
Yeah, it was about more about the approach to screening for rainbow whānau and for trans and non-binary people. So a little bit different from Esther's question.
Thank you for that question. It is definitely something that has been in conversation in the national screening program around how patients are identified and getting recall notices. I'm again probably not the best person to be asking about that, but I think our research group is a big fan of trusted primary care, and so the National Cervical Screening Program has it is usually run through primary care. That's, primary care sends out your reminders, and most people will go through primary care to get their screen. And then there's also the register, which can send out the reminders as well. And there was some talk about the centralized register taking over as being the main point of contact for recall in the new program. And we have really pushed against that idea because, and although, we acknowledge that not everyone is registered with primary care, and to be honest, I don't have a GP at the moment. So, but I think, from the primary care practices that we've worked with, there are always champions there who are ensuring that trying to ensure that they're contacting whānau in the appropriate way. And so I think there's definitely room for the register and for things to perhaps not get things right, but I would hope that there would be the safety net of the primary care who can also be a point of contact. But yes, in saying all of that, I think it's a really important point to be raised with the National Screening Unit around the register and ensuring that people could have, their gender, and regardless of what gender they're noted as, that they can still have a screening recall come through, and that it doesn't misgender them. Yeah.
Awesome. Thanks, Hannah.
Lovely. Thank you so much. We're out of time. I feel like I had like 5 questions for you, Hannah, so maybe I'll follow up. But I just want to thank you all for coming and would encourage you to share this series. We just want to broaden our audience, so please forward as you see fit. And thank you again, Anna, and all of you for coming today and participating. I hope you have a lovely day and see you next time.
Thank you. Kia ora koutou.
Okay.
Kia ora.